Yeibwoti emet kotugul agobo kaimutietab fistula en arawetab mut kokimi Uasin Gishu County ole mite sipitalit neinegen en emetab Kenya nebo fistula. Gynocare Women's and Fistula Hospital kotinye konyoik, counselors ak ng'omutik alak cheterter chekikokongei koyai boisiet asikomuch kowal sobetab kwonyik chetinye fistula.
Yeah, fistula is a very common condition in Kenya, and it's widespread in the entire region. It's quite common in Western Kenya, quite common in the pastoralist communities in Nyanza, and it's purely caused by difficult labor, obstructed labor, where a patient is not able to get to hospital in time, and she labors at home, and most of the time her baby dies. And by the time she gets to the hospital, it's too late. Even if a cesarean section is done, this baby has already damaged her bladder and other systems. So the patient now comes in, she loses her baby, and then she gets this very devastating condition called obstetric fistula, which is a condition that has continuous leakage of urine and stool. And so because of the smell, these women are ostracized from society. So they are not like acceptable in a home. So some of them are divorced and sent away to their homes, and even some family members don't stay with this kind of patients.
Kosubkei ak kanyoindet agenge kobun Uasin Gishu County, Hilary Mabea, ko fistula komuche kosich kwonyik age tugul kong'eten lagok chemengech.
Actually, fistula affects so many different people. Apart from the women who have had delivery, obstructed labor, difficult delivery, fistula. There are also those women who have gone for cesarean section, they get fistula. Women who have had operations for other conditions, fibroids, they get fistula. There are also women having cervical cancer who actually get fistula from the advanced cervical cancer, and it's unfortunate that our women also are dying from cervical cancer and fistula, when you can even prevent this condition from the start. We have also the young girls who are sexually molested. Very many who end up in Gynocare and other hospitals with fistula, and they need help or treatment. There are also women who get trauma. They fall down, they get hit by something, they get an accident, they get fistula. All these ones are actually fistula that can be treated. There are also those ones who are born with fistula. Women who have what we call congenital fistula. We see a good number of those patients here, and a good number of them have had a live treatment event where they have had treatment and recovered well. They are born with fistula. They stay for many years. Some are teenagers, some are 20 years old. They end up coming with fistula. So all this kind of a spectrum of fistula are actually treatable if they are managed well and they taken to the right place, and Gynocare is able to do that. Yeah, sadly, almost close to 15 to 20% of patients we see at Gynocare are actually as a result of either post-cesarean section with results and damage to the bladder and the ureters, or a patient who has had a hysterectomy through many other reasons, and then she develops leakage of urine after surgery. Sadly, because now these are patients who have been operated and they develop this kind of condition which they should not develop. But so Gynocare handles those kind of patients who have had a post-surgical injury from another operation that causes urine and stool incontinence. So we operate that, and we also train the doctors on good surgical skills to actually prevent this kind of injuries. And of course, it's also important that our medical schools also improve in terms of continuous training.
Kora, komiten tuguk cheterter cheimuche koyai kwondo kosich fistula kou ole kamwa kanyoindet noton.
I think there are multiple factors. One, home deliveries. Another one is young age at first delivery. And again, more so maybe distance from the hospital to the home to the hospital, so that the mother is not able to reach her in time for a specialist care. If she needs a cesarean section, then she's not able to reach in time, then she gets obstructive labor. So I think young age, then poor obstetric care, yes, and distance to hospitals. That can be a big reason why we have so many patients. I think, again, we have done a lot of community outreach in these areas. We have done a lot of work in Western Kenya, Live to Fallen, we have done in Nyanza, so that could explain why many patients come this way. But I'm sure in the entire country, Narok and other parts of the country, there could be many others who have not had a chance to know where they can go for treatment.
Kosubkei kanyoindet age, Samuel Munyoki, kobune konyi kaimutik chechang yon kasich fistula.
In most cases where fistula occurs, there is obstructed labor. When obstructed labor occurs and it lasts for a long time without relief, a lot of tissue gets damaged, and the most likely to get damaged is the bladder because it's very close to the uterus. So in the event that she goes through obstructed labor for maybe 2-3 days, sometimes the baby dies. When the baby dies, usually the head collapses a bit, becomes smaller, and might come out because of the size. Now, in that scenario, the patient has lost her continence. She has also lost her baby, which is very painful. So she's trying to recover from the loss of the baby. At the same time, she realizes she's incontinent of urine. Most families give support to the women at that point. But after a few months, when there is no solution, they start thinking otherwise. Like, this lady now is not able to have a child, is not looking like she can function normally, she's smelling. So they start looking for a plan B, and some men will look for another wife, even if they're not going to tell her to go. Sometimes they just tell her to go, or they just start treating her in a bad way that she will go. So this is not the third loss. Losing your incontinence, losing your baby, now losing your spouse. That's a lot to bear. At the same time, the lady is still recovering from the trauma of childbirth. And in this case, it's actually a big trauma.
Kakingalal ak kwanda agenge netetat keyochi konyoisetab fistula akomwochi inendet akobo ole kisich fistula ak kit netetat koyoe inendet yon kakosob.
Mimi naitwa Karen Achieng, natoka Kisumu. Nilipata shida ya hii fistula 2013 wakati nilizaa mtoto yangu ya tatu. Ya kwanza nilizaa kwa operation, nilikuwa kubwa. Ya pili nilizaa reserve kwa kienyeji. Nilizaa reserve 2011, mtoto ilikuwa kubwa ikakufa. Tena 2013 nikapata mimba ingine, tena ikatoka. Sasa hiyo mimba ikizaa toka, damu ya kuzaa ikiisha, ndio inaanza kuona hiyo shida ya fistula. Sasa nilikaa na hiyo shida, sikujua hiyo shida inaweza pata treatment. Nilikaa tu na hiyo shida kwa nyumba kuanzia 2013 mpaka 2019 leo. Hii shida vile nilipata, hata mimi sikujua naweza pata hii shida. Sasa nilikaa na hii shida kwa nyumba, hata hospitali sijaenda. Sababu nikienda hata kuuliza watu wa Kisumu, wananiambia ati hii shida inataka pesa mingi. Nilisaenda Rasia. Siku ya kwanza nilienda General. Watu wa General wakanipeleka Rasia niende niulize huko. Nikaenda kuuliza huko kwa daktari mwingine anaitwa sijui Utena Kula, Dr. Utena Kula. Akaniambia hiyo ugonjwa inakujanga tu na wakisa kuja wanaenda. Wakisa kuja wanaenda. Wacha tungoje wakikuja nitakuita. Nilingoja huyo daktari mpaka saa hiyo hajaniita. Sasa nilikuwa tu kwa nyumba, nikienda kuuliza hii mgonjwa unaweza tibu na pesa mingi, na hiyo pesa siwezi pata. Sasa nikaamua tu nikae tu kwa nyumba. Nilikuwa tu natumia tu manguo kwa nyumba, hata sokoni siwezi enda, hata matanga siwezi enda, niko tu kwa nyumba. Niko sasa nilikuwa tu na hiyo shida kabisa.
Na familia?
Familia hakuna, hata mzee alikufa 2014. Sasa nilikuwa tu na hiyo shida kwa nyumba mpaka siku ya leo. Sasa ya kukaa na hii fistula, matusi ilikuwa mingi sana. Hata ukienda kwa kisima, shemeji yangu anaweza sema usirudi tena kuchota maji. Bwana alikufa tu 2014 akaniwacha na shamba. Shemeji yangu alichukua hiyo shamba sababu alikuwa nafikiria naweza enda kutafuta title deed ya hiyo shamba niuze, niende nayo hospitali. Familia ya wazazi alikuwa anasema ati hiyo ni ugonjwa ya kawaida tu, kaa tu na hiyo ugonjwa. Usiseme ati hiyo ugonjwa unaweza pata treatment. Wewe vumilia na hiyo ugonjwa ni yako, vumilia tu na hiyo ugonjwa. Sasa nilikuwa nasikia tu hii kitu kwa redio. Nasikia tu hii kitu kwa redio kama watu wanaongea hii shida inaweza pata treatment. Sasa nilichukua namba kwa redio. Sasa hiyo namba nilichukua 2017. Kwa redio nilisikia kama mtu anaweza kama uko na ugonjwa ya fistula. Hii kitu nilisikia kama inaitwa kwa redio ati fistula. Mimi sikujua hii ugonjwa ni fistula. Nilisikia tu kwa redio hii fistula, kama uko na fistula unaweza enda hospitali upate matibabu free, ati wasungu anaweza saidia watu wa Kenya bila malipo. Sasa nilikuwa nasikia tu hiyo redio mpaka nikachukua namba. Nilikaa tu kwa hiyo namba kwa muda sababu sikujua unaweza piga simu haraka tena unaweza unaweza stuka. Sasa nilikuwa nakaa na hiyo namba, pengine naweza flash na kata mpaka nikajitolea nataka kuongea na madam mzuri nieleze niende hospitali. Tulikutana na yeye Kisumu 3 weeks ago. Akaniambia hii shida inaweza isa, nipate tu nafasi ya kutoka tu kwa boma. Aliniambia hivyo mpaka nikafurahi. Huyo madam aliniambia tu direction. Aliniambia nitafute tu fare. Natafuta fare, alafu akaniambia direction ya Eldoret. Mimi sijawahi kuja Eldoret. Kwa sasa tulikuwa tunaongea na yeye kwa simu. Nikapata gari from kwangu mpaka Kisumu stage 200. Kisumu stage mpaka Eldoret stage hapa tena 600. Sasa nilikuwa natafuta 1000. Aliniambia nitafute fare. Nikisafika Eldoret nikapigia simu, nimesafika hapa Eldoret nifanye aje, na sija hata wazazi yangu hakuna hata area ya Eldoret, hata hapa mimi sijui. Akaniambia niite mtu wa bodaboda, anataka kuongea na mtu wa bodaboda ajue mahali naenda. Nikapea mtu wa bodaboda simu, akaongea na yeye atene kuja tu mpaka Gainokea hapa. Nilikuja tu na pikipiki paka hapa kwa gate. Nikisafika hapa kwa gate nikapigia yeye tena simu. Akaniambia tu niingie tu hapo nikisafika kwa mali ya reception nimwambie ati huyo ndiye amenituma nikuje hapa. Nikisafika hapa watu walinikaribisha kabisa, sikukaa. Nikisasikia niko na shida ya fistula, wakaniambia tu niende nilale kwa kitanda. Mpaka saa hii naona kama shida hakuna hapa. Unajua nini madam? Hii ugonjwa naona kama iko sijui watu wa sita. Tunaombanga na yeye kwa kanisa moja. Mimi naweza enda kanisa dakika kidogo, naona kama hao watu iko na hiyo shida kama yangu. Na wanaogopa kuongea na huyo madam, hata naona aibu. Sasa mimi nikipona, nikiona nimepona naenda kutangaza usinyamaze na hii ugonjwa kwa nyumba. Hata madam mwingine nilisaongea na yeye wakati nilikuwa hapa jana. Akaniambia, nikaambia madam sasa niko Eldoret kwa ile ugonjwa. Akacheka. Eldoret huwezi pona. Unaharibu tu masaa bure. Sasa nataka nikipona au watu waone nikisapona wakuje tu hospitali hata pia wao wapone.
Kosubkei ak Samuel Munyoki, komitei sticho terter chekeyochin kwonyik kotomo keyochi katitaetab fistula.
For any patient to undergo any kind of examination, he or she must give a consent and actually understand what it entails before you start the examination. Usually, when is a male nurse or a doctor, we encourage to do an examination with a female colleague, and that creates some confidence in the lady. But all the time, the patient must understand exactly what is happening to her and give consent for the examination every time. If it's a minor, usually the parent should be there, or if the parent is not there, a guardian must be there. And at the same time, the child must understand what's being done to her. And of course, there are limitations to what you can do and what you cannot do. If it comes to a point where the examinations can be uncomfortable, we ask the parent or the guardian to give us a consent to take the child to theater. We do the examination under anesthesia so that it is bearable or comfortable for the child. Screening in this sense means the patient comes to you. She explains issue. Usually they talk about some form of incontinence. So the screening starts from the talk. That is what we call in medical history taking. She tells her what happened up to where she is. Then you do the examination after, of course, explaining to the patient, and you determine whether she's leaking from a fistula or some other kind of incontinence. Of course, we do a full physical examination of a patient, like to know if she has any deformities or she has any other problems in her body. But we measure in the incontinence area that pertains to the urinary system. That is where we measure. Like sometimes we might have use a few instruments, of course, as comfortable as possible, to make a diagnosis and determine if she has a fistula or she has some other kind of incontinence.
Kora, konyoisonoton kotiengei oleu fistula.
Yeah, fistula surgery can be complex, and partly there was a myth from the doctors that fistula surgery was difficult. Of course, the other myth is fistula surgery is not a well-paying job because the patient will not pay you for the surgery. With good training, before maybe 10 years ago, success rate for fistula surgery was less than 40%. But right now we are actually at more than 85% success rate. When you see the patient operate, you first surgery, 85% success. And this depends on not many factors. One, good post-operative, pre-operative and post-operative preparation. And the other one is the age of the patient, the type of fistula we see. There are some very difficult ones, for example, from the communities that have undergone FGM. Those ones we get very difficult cases. And the very young mothers, less than 15 years old, 14 years old, those ones are very difficult fistulas. So it actually depends on the community where patients come from, the age of the patient, and then the cultural traditional practices like the FGM. Yeah, those kind of patients have very difficult very difficult fistula. And then there are these other ones where you have seen many attempts of surgery. A patient has been operated more than 10 times. Those ones are very difficult also. Yeah, but overall success in skilled hands is more than 85%, way up from 40%.
After the examination, we decide on the, depending on the type of incontinence that we find, because there are some form of incontinences which are not fistula, which can be managed otherwise without necessarily having to undergo surgery. So we advise the patient, sometimes we train them on some kind of exercises, and sometimes they require medications because they might have an infection like urinary tract infection. Then if it's fistula, or if it's something that can be corrected in our setup, we admit them. We give them a bed in the ward. We check if they have enough blood, if they need to go to theatre. We check some chemistry in the blood just to be sure they are healthy enough. We check if they might be diabetic, hypertensive, just to make sure they are healthy enough. Of course, we explain to the patient and they give consent if they need to go to theatre for a surgery. Then we explain to them the possible outcomes of the surgery. Sometimes it works, in a few cases it may not work, because there is no treatment like for fistula, which you can say is 100%. Most of the surgeons who do fistula repair will give you a success rate of 70 to 85%. A few will give you a success rate of 90%, or slightly above. But in our case, in the case where we cannot cure the fistula, we have what we call diversion, which is like a solution to the kind of incontinence which cannot be sorted through fistula surgery. In the meantime, the primary thing is surgery to repair the fistula. Now that you've mentioned about diversion basically means you divert something from one system to another system. That means you divert the urine from the urinary system, which is not functioning well, and we reimplant the ureters to the bowel, so that the system doesn't work normally, but it allows the lady to be continent. The repair surgery, we take the patient to theatre, of course under anesthesia, because every surgery needs anesthesia. Then the surgeon, of course, dissects the area and does a surgical repair. And after closing the fistula, they do what we call a dye test. It's just a way of putting some colored solution so that you can see if there is a leak. If there's no leak, now you know you have closed the fistula. And most likely the patient will be continent.
Kamuni muche kosich infection konyichuton keyochin chikilisiet en abokora.
Follow up, of course, after discharge, the lady goes home. We see her after 2 weeks, then after 3 months and 6 months, or according to their specific needs. So in the follow-up, we ask a few questions just to see how she's doing, how the family is incorporating her, how much support she's getting from the family and all that. And of course, we assess her healing, her level of continence. There's always a chance of infection. Even without surgery, you can get infection. And of course, when you surgery, some people call it like intended trauma. Of course, it's like you are injuring somewhere to make it better. So there is also the fact that you can be susceptible to infection, but we do a lot of caution on that. We make sure the wards are clean. We make sure that the women are given right education. The nurses do a check like twice or thrice a day, just to make sure that the operated area is clean enough, or they actually take lead in cleaning the operated site, and educating the patient to keep on cleaning herself in the ward and at home. Once in a while we get infections, and as soon as the infection by chance sets in, we treat it aggressively. with what we call systemic antibiotics and local. Local means just on the area, around the area. Or systemic means when you take the drug and it gets in the blood and works everywhere in the body. So we don't get much of that. But once in a while, you might find that. We also have a challenge where you find a patient comes and she has malaria. So we have to treat the malaria first. You might also find a situation where a patient comes and she has diabetes. She didn't know. Or she's hypertensive, she doesn't know. So we have to check all those because they can also impact on the post-operative care. Because if somebody is diabetic and you don't know, then you take them to theatre. You might have a big problem in the theatre. And if not, you might have a big problem in the recovery. But if you control, then you'll be fine.